Welcome to The Explainer. I am absolutely thrilled you're joining me today because, well, we're going to look closely at something literally every single one of us has experienced firsthand. Usually right before a holiday or a big vacation, right? We are unpacking the Upper Respiratory Tract Infection, or as it's most commonly known, a URTI. It's a universally common clinical presentation, whether you're working in a clinic, studying for your medical boards, or honestly, just trying to understand why you feel so incredibly miserable every winter. This is absolutely essential knowledge. There is some truly fascinating, precise science behind that everyday sniffle and cough, and we are going to break the whole shebang down together.
Okay, let's dive into this. Here is our roadmap for today. First, defining URTIs. Second, etiology, specifically the viral majority. Third, clinical progression. Fourth, targeted investigations. And finally, number 5, evidence-based treatment.
So, Section 1, defining URTIs, anatomical boundaries. A URTI is strictly defined as an infection involving structures above the larynx. That is your hard anatomical cutoff line right there. The larynx, or your voice box, basically serves as the gatekeeper. Anything happening above that structure, like your nasal cavity, your sinuses, your pharynx, all of that is classified as upper respiratory territory. Now, if an infection moves below the larynx into the trachea or the lungs, well, then you're dealing with a lower respiratory tract infection, which is an entirely different clinical ballgame. Keeping this boundary in mind sets the perfect foundation for the rest of this explainer.
Moving right along to Section 2, etiology, the viral majority.
Now, what's really interesting about this slide is how these statistics dictate everything about how we handle this illness. More than 90% of all URTIs are caused by viruses. That leaves only a tiny, maximum 10% sliver for secondary bacterial infections. So, when a patient presents with upper respiratory symptoms, the statistical odds are overwhelmingly pointing to a viral etiology. It is incredibly important to anchor your understanding in this 90-to-10 ratio. Seriously, keep that in the back of your mind.
So who are the usual microscopic suspects making up that massive 90% viral majority? Well, we're talking about pathogens like rhinovirus, the classic culprit behind your common cold. Then you've got coronavirus, influenza virus, adenovirus, RSV, and parainfluenza virus. These viruses are just incredibly efficient at hijacking the mucosal cells above your larynx. They spread like wildfire, they replicate super fast, and they are exactly why viral infections absolutely dominate this anatomical space.
However, we can't entirely ignore that smaller 10% slice of the pie, right? While viruses are the primary, instigating driver, we can sometimes see secondary bacterial infections move in. This usually happens after the initial viral infection has already caused inflammation and, kind of weakened the local immune defenses. The 3 specific secondary bacterial pathogens you really need to commit to memory are Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. Think of them as opportunistic invaders, just waiting in the wings for the viral infection to pave the way.
All right, Section 3, clinical progression. A URT generally follows a very predictable sequence. Phase 1 usually kicks off with nasal congestion and rhinorrhea, which is just a fancy way of saying that classic, super annoying runny nose. Then, moving along the timeline to Phase 2, a sore throat and a cough typically develop. This happens as post-nasal drip and localized viral replication really start to deeply irritate the pharynx. Finally, hitting Phase 3, the patient might start to experience systemic symptoms. We're talking a low-grade fever and general malaise or fatigue. It's a very stepwise, sequential journey, starting from the nose, moving down to the throat, and then eventually zapping the whole body's energy levels.
But here is the crucial point to remember. Most of these infections are mild and self-limiting. I know, despite how truly miserable that progression of congestion, severe cough, and fatigue might make a person feel, a healthy immune system is fully equipped to handle it. The infection's going to peak, it'll run its natural course, and it will resolve on its own without requiring any dramatic medical intervention.
Next up, Section 4, targeted investigations.
And this brilliantly illustrates how we decide whether to actually test a patient. There's a clear dividing line in medical management here. On this side, we have the standard approach, clinical diagnosis. Because of the viral nature of the illness, for the vast majority of URTIs, laboratory investigations are completely unnecessary. You diagnose purely based on that clinical timeline of symptoms we literally just discussed. But compare that to the right side. Investigations are required when you have suspected bacterial complications. So it's a very clear divergence, right? Trust the clinical presentation for the everyday cases, but be ready to investigate the second specific red flags appear. So what exactly are these red flags that justify escalating to further medical investigation? Well, the source material gives us 3 very distinct warning signs to look out for. First, a persistent fever that just won't break. Second, severe unilateral facial pain, that is, intense pain strictly on one side of the face, which actually often points to a localized sinus complication. And third, symptoms lasting for more than 10 days without any sign of improvement. Listen, if a patient hits any of these specific criteria, the whole clinical picture has shifted. It is time to investigate further to see if that small bacterial minority has somehow taken over.
Which brings us to our final part, Section 5, Evidence-Based Treatment.
Because we know these infections are mostly viral and mostly self-limiting, the primary treatment plan is entirely focused on symptomatic management. It's a conservative, highly restorative approach. We're looking at simple analgesics, like acetaminophen or ibuprofen, just to handle the low-grade fever and those awful body aches. We utilize nasal saline irrigation to physically clear out that persistent congestion. And, of course, the absolute fundamentals, adequate hydration and rest. This protocol essentially gives the immune system the time, energy, and environment it needs to just win the fight naturally.
But this leads us to a massive, truly provocative question. In fact, it might be the single most frequently debated question in modern outpatient medicine. When are antibiotics actually indicated for URTI? I mean, think about it for a second. We have all seen patients urgently demand them, or, let's be honest, perhaps we've even expected them ourselves when feeling under the weather. Well, here is the definitive answer, and it is absolutely the ultimate clinical pearl to take away from this explainer today. Antibiotics are not routinely indicated unless a bacterial complication is confirmed. Remember that massive 90% viral majority we talked about earlier? Antibiotics do absolutely nothing against a rhinovirus, an adenovirus, or influenza. Literally nothing. Prescribing them without one of those specific bacterial red flags, like the unilateral facial pain or symptoms lasting way past 10 days, it doesn't help the patient at all. It merely contributes to the massive global crisis of antibiotic resistance. So you have got to stick to the evidence. Trust the clinical progression, rely heavily on symptomatic management, and save the antibiotics only for when the data absolutely confirms you need them. It leaves us with a pretty critical question for both doctors and patients alike. The next time a common cold strikes, will we have the patience to let our immune systems do their job, or will we demand a pill that might just make the next superbug stronger? Thanks so much for exploring this with me today on The Explainer.